Hello, welcome. This webinar series, Designing for Behavior Change, a human-centered approach to research and intervention, is brought to you by the Human-Centered Design Task Force of the American Heart Association's Healthcare by Food initiative. This series is part of the initiative's cooperative studies model, designed to foster shared learning and innovation. Welcome to session 3 of our 4-part series, designed to equip you with human-centered design tools and mindsets to strengthen and expand your research approach. Today, we'll be building on the foundations from session 1 and session 2, continuing to deepen our understanding and application of the frameworks you learned there. It is important and necessary, though, to start with this disclaimer. Statements, opinions, and study results presented in this presentation may not reflect the policy or science position of the American Heart Association, unless otherwise noted. In today's session, session 3, we will be combining the CALM-B behavior change model and journey mapping framework. Our goal in this session is to create nuanced behavior change strategies by merging two powerful human-centered design frameworks. We'll use this combined approach to refine the food as medicine journey, focusing on critical behaviors that need to be enabled for successful outcomes. By the end of this session, you'll be able to do 3 key things. First, you'll refine the food is medicine journey by pinpointing the most important behaviors at each stage, those that are essential to achieving impact. Second, you'll know how to combine the CALM-B model with journey mapping to design interventions that address behavior change in a more comprehensive way. And third, you'll explore how to apply this integrated framework directly to your own research, improving how you design your interventions and target your studies. Now let's get started. Explored in depth in session 2, the food as medicine journey represents the individual's end-to-end experience, beginning with a clinical interaction in which the healthcare provider offers a food is medicine prescription to the patient. Depending on the nature of that prescription and the type of food intervention it involves, the individual may need to engage in meal and food planning, such as creating a shopping list or mapping out meals. Next, the individual must select appropriate food, which may include both items covered by the prescription and any additional ingredients needed to convert the provided food into a consumable meal. This food must then be purchased and somehow brought into the home, whether by the individual, through a traditional grocery shopping experience, or via delivery. Once in the home, the last mile of this journey is just beginning. The food may require varying levels of preparation. For example, medically tailored meals, or MTMs, may only need reheating, whereas a produce box may demand extensive or novel preparation methods before the food can be consumed. Ultimately, though, the goal is for the individual patient to consume the healthy food as intended, which, with consistency and time, we believe will lead to improved health outcomes. In session 2, we emphasize that each and every stage of this food as medicine journey is not only important, but is part of a cascading chain of dependencies. Every stage of the journey is a critical step that must be traversed successfully in order to advance to the next. For example, healthy food can only be consumed if it's properly prepared. It can only be prepared if it is available in the home. And it will only be available in the home if it has been selected, purchased, and acquired, and so on and so forth. Each journey stage, then, is more than just a step in the process. Each stage is actually anchored by a specific critical behavior that must be carried out successfully. If any of these behaviors in the journey fail, the individual may not consume the food as intended, and the opportunity for improved health outcomes will be lost. Both the Healthcare by Food initiative as a whole, as well as individual study teams, must consider how research advances our collective understanding, how interventions, and ultimately evidence for behavior change across the journey. So we can refine our goal to this: to enable a healthy human behavior at each and every stage of the food as medicine journey. In enabling behavior, we can leverage the COM-B behavior change model that we introduced in session 1 to better understand and enable behaviors at each stage of the journey. Both of these frameworks represent systems. The journey consists of interrelated, dependent stages, each one influencing the next. Similarly, the COM-B model includes 4 components that interact dynamically, offering a theoretical foundation for understanding and enabling behavior change. In this session, we're bringing together these 2 human-centered, systems-oriented frameworks, integrating them to form a more powerful and nuanced approach to designing research and interventions. As a quick review of COM-B from session 1, we explored how the COM-B model helps us understand the ways an intervention can influence behavior, specifically by acting on 3 core factors of capability, opportunity, and motivation. For any given behavior, there is a threshold that must be met for change to occur, noted here in the graphic by a green line. Shown in orange, individual interventions act to raise one or more of the individual factors of the COM-B model. One example of this is how a cooking class can build skills, increasing an individual's capability to prepare healthy meals. Systemic interventions, illustrated by the green arrow, take a different approach. Rather than building up the individual, they actually lower the threshold needed for behavior change by reducing the demands on the individual. An example of a systemic intervention is a meal kit, which simplifies meal and food planning and food selection, making preparing healthy meals more achievable with less individual effort. That is, less effort by the individual patient. Together, these illustrate the 2 primary interventions, individual and systemic, that can support behavior change by either strengthening the individual's COM-B factors or by acting on the environment or system to reduce barriers, ultimately making the desired behavior more easy to achieve. While we previously explored how to leverage the COM-B model to understand general behavior change, we're now going to take it a step further. In this session, we'll apply COM-B at the stage level, focusing on what it takes for an individual to successfully move from one stage to the next in their food as medicine journey through behavior change at each stage. Let's first apply this idea to a specific journey stage. As an example here, let's look at the stage of food selection, where the target behavior is selecting healthy, appropriate food. Let's consider 3 different interventions and how they support behavior change in this specific stage. Keep in mind, the green line on this graphic represents the threshold needed for sufficient behavior change across the COM-B factors of capability, opportunity, and motivation. Note that while not all factors must be addressed, at least one must be acted on to elicit the desired behavior. First, we can consider medically tailored meals, or MTMs. MTMs provide ready-to-eat meals delivered to the individual, reducing the behavior threshold for capability, opportunity, and motivation so significantly that MTMs effectively obviate the need for any behavior in this stage by the individual. The selection of healthy food is done for you by the MTM provider. In this way, MTMs act as a powerful systemic intervention in food selection. Second, consider community health workers, or CHWs, who might accompany an individual to shop for groceries. CHWs provide hands-on support, offering skills and guidance within the person's own context, that is the patient's own context. For example, a CHW might walk through a local grocery store with someone, helping them read nutrition labels and choose culturally relevant healthy options. This kind of intervention acts on the individual, primarily increasing capability and motivation through personalized coaching and support. Lastly, let's consider a third option. Consider modifying store choice architecture, particularly relevant in online grocery platforms. By designing the interface so that appropriate healthy foods are prominently featured and easier to choose, this intervention alters the environment or system. For example, an online app might automatically suggest fresh produce or whole grains at checkout, or display low sodium options at the top of search results. This reduces the need for high levels of individual capability or motivation, making healthy choices more automatic, easier. This is another example of a systemic intervention that changes the environment or system to support the individual's behavior change, particularly in food selection. These three intervention examples considered together show that there are a variety of intervention elements that can act in a single journey stage. Some alter the system or environment to reduce barriers, whereas others strengthen individual capability and motivation. Each uses different mechanisms to enable behavior change. Now, let's expand this thinking across the journey. Let's take a closer look at a single intervention and explore how it enables behaviors across different stages, either by acting on the individual level to increase capability, opportunity, or motivation, or acting at the systemic level to reduce barriers and make behavior change more achievable. Let's consider a couple of examples to illustrate this idea. First, medically tailored meals, or MTMs again, are a systemic intervention that we've discussed before. MTMs act in 5 journey stages: food and meal planning, food selection, purchase, acquisition, and preparation. In fact, MTMs completely address food and meal planning, food selection, purchase, and acquisition, eliminating any need for individual capability or motivation to do those behaviors, and largely eliminating barriers to opportunity, speaking in COM-B terms. And the preparation stage, where the green arrows are a bit shorter, the story becomes more nuanced. MTMs clearly reduce the need for capability, as they often require little more than reheating. However, their influence on motivation is less clear. It is suspected that motivation is affected by feeding the household versus feeding just the individual patient, though more evidence is needed in this area. As for opportunity, it's highly dependent on individual contexts, such as available time, social barriers, or access to basic resources like a microwave for reheating. These factors can significantly influence whether preparation is feasible, even with MTMs. While MTMs go a long way in supporting healthy food consumption across the journey, we can also see that they don't do it all. On their own, they don't guarantee that the intended individual actually consumes the meal as designed. Next, let us consider nutritional education, which is an individual intervention that acts to increase capability, most specifically knowledge. Nutrition education can be structured to scaffold knowledge across the continuum, helping individuals not only understand what to do, but why and how. This not only increases knowledge, but can also raise motivation, enabling sustainable behavior change. Nutrition education can target many different stages of the journey. For example, in food and meal planning, we could teach how to build balanced meals using dietary guidelines. In food selection, we can discuss how to choose foods aligned with specific health goals, such as low sodium or high fiber. In purchase, we can teach strategies for smart grocery shopping on a budget. In acquisition, we can educate on eligibility for support programs and community resources. In preparation, we can demonstrate simple, healthy cooking techniques. And in consumption, we can teach portion control, mindful eating habits. Given the wide range of knowledge that can be shared, nutrition education can be strategically tailored to target specific journey stages and even designed to complement other interventions by acting upon stages that might otherwise be unaddressed. Now let's look how a targeted nutrition education might complement MTMs. We can intentionally combine medically tailored meals with nutrition education. That education that is specifically targeted to the preparation and consumption stages. In doing so, we can build a more comprehensive food as medicine program, one made up of complementary elements that collectively address key behaviors across the journey. As we've discussed, MTM can bypass the need for individual behavior change across several journey stages, delivering meals directly all the way to the point of consumption in the home. However, an MTM alone does not actively induce the consuming of the food. This is where targeted nutrition education can play a critical role by increasing knowledge, shifting attitudes, and building motivation around MTM usage and healthy food consumption. Together, MTMs and this targeted nutrition education shown here can support the full FIM journey. But importantly, this only happens after clinician engagement and the provision of the prescription itself. I point this out to highlight yet again how the success of later stage interventions depends on earlier stages being successfully completed. While many studies may not directly engage with the health system portions of the journey, it is important to acknowledge these dependencies when designing, implementing, and evaluating our interventions. Combining intervention elements like this is essential to fully address behavior change across the entire journey. Food as Medicine Journey Map, when paired with the COM-B model, gives us a structured framework to intentionally design intervention portfolios, combining distinct but complementary elements to improve outcomes and generate meaningful, actionable evidence. Now, let's apply these ideas to a pilot study example from session 2. As a reminder from session 2, the goal of this pilot study is to evaluate strategies to increase food consumption of produce provided through a home delivery-based food prescription program. We see the 3 main interventions mapped to the journey, exactly as we explored in session 2. Now let's take these interventions and frame them with our coupled COM-B and journey framework. The first element is the produce boxes, which are a systemic intervention acting to lower barriers. However, as you can see, the systemic action is varied across the journey and across COM-B elements of capability, opportunity, and motivation. Let's look at this a bit more closely as I highlight a few key points. In food and meal planning, as well as the food selection stages, produce boxes can have a mixed effect. On one hand, they reduce the individual's need to actively select healthy, fresh foods, as those foods are provided for them in perhaps a produce box, lowering the demand on capability and decision-making. On the other hand, they also increase the complexity of planning and selection. The individual now needs to adapt their meal planning around a set of pre-selected items, which may be unfamiliar or not aligned with their food preferences. Complementary ingredients are often required, which the individual must identify and acquire on their own. This also raises the required capability in preparation. This dual effect is why we show produce boxes having both an upward and downward green arrows, reflecting a decrease in some behavior change demands while potentially introducing new ones. And preparation shows an upward green arrow only, as the potential unfamiliar, pre-selected fresh produce from the box may require additional skills or knowledge to prepare. Delivered produce boxes do eliminate the need for individuals to purchase and acquire fresh produce themselves. However, as we noted previously, additional ingredients beyond what is provided in the box will still be needed, and you'll have to source those separately. This is why the green arrows shown here don't fully reduce the threshold. The novelty of new produce, interesting things, may generate some excitement and motivation for some individuals, inspiring and encouraging them to plan, prepare, and consume these new, novel, and healthy foods. This is indicated by a small green arrow in these boxes, lowering the threshold for motivation. So this is the profile of produce boxes across COM-B and the journey. Now let's add the next element, nutrition education. Nutrition education, represented by the orange arrows here, is an individual level intervention. In this pilot study, the education was focused on food and meal planning, selection, and purchase, with the goal of increasing the individual's knowledge in these areas. Lastly, we introduced the AI app, which helps generate food preparation ideas and boosts engagement with the delivered produce, thereby addressing the preparation stage. Specifically, the app enhances knowledge and skills by offering recipes and ideas while also providing encouragement and motivation. Looking across all three elements of this pilot study, we can see intentional design and the complementarity of the elements, ensuring that every journey stage after the prescription is addressed through at least one component of the COM-B model. Now we have a powerful framework to guide us in designing research that enables effective behavior change by targeting capability, opportunity, and/or motivation, all grounded in the theoretical framework of the COM-B model, and addresses the full cascade of behaviors required to ultimately achieve consumption. Then and only then we can achieve the subsequent improvement in health outcomes that we aim to build evidence towards. Our exercise for this session builds on exactly what we've been walking through. Pictured here is the worksheet to support this exercise, which you can download and print or complete digitally with your team. For this exercise, you will complete a separate worksheet for each of your study interventions or intervention elements. That is, for each of those individual things you listed on the Session 2 exercise worksheet. In the case of Pilot Study 2, which we just looked at, they would complete 3 separate sheets, one for produce boxes, one for nutritional education, and one for the AI app. For each isolated element, you are going to complete the same exercise we just walked through with Pilot Study 2. Use the checkboxes to mark which journey stages the intervention element addresses, building on that same exercise from Session 2. For each stage marked, indicate how the intervention influences one or more components of the COM-B model, which you can see laid down the left-hand side of the journey, each in line with their corresponding rounded boxes. In each of these rounded COM-B boxes, individual interventions can be represented with an up arrow from the bottom, indicating the increase in that factor for the individual. Systemic interventions can be represented with a downward arrow, indicating the lowering of the threshold for behavior change. And additionally, as we saw with produce boxes, some interventions may require upward arrow to reflect an increase in the threshold, depending on the specific intervention. So this is our exercise for this session. And again, before you get started, I'd like to share a few insights we've gained from working with study teams using this framework. We hope you find these helpful in getting the most from the exercise. The first off is that many studies tend to center food provision, with additional elements seen as supporting that core food offering. However, there is significant potential and reframing all study elements as part of a cohesive behavior change strategy. In this approach, each element contributes differently to behavior change at specific journey stages. By viewing study elements in this way, we can design portfolios of complementary interventions that increase the likelihood of successful consumption, improved health outcomes, and ultimately more evidence supporting food as medicine. In session 2, we mentioned that support elements are typically underspecified in studies. The framework we explored today can actually help support further specification of these elements by the journey stages, targeted, and the mechanisms for behavior change, such as capability, opportunity, and motivation. While systemic interventions like MTMs can reduce or even obviate the need for behavior change in some stages, we have to consider what happens when the individuals transition off of these interventions. Is there a way to induce longer-term behavior change that lasts beyond the intervention? How do we do this? Should we gradually taper reliance, or should we transition to another different intervention? Regarding journey gaps, take a moment to review your worksheets and identify any stages that may not be adequately addressed. On a broader scale, the food as medicine field must similarly work toward building comprehensive evidence across the journey and behavior change strategies, even in areas that are often overlooked, such as healthcare interactions and actual consumption. Lastly, for the human context, the heart of human-centered design. The in-home environment, the last mile, presents many underexplored yet critical questions ripe for research. For example, factors such as the individual's access to kitchen tools, social dynamics within the household, and the influence of time constraints all play a critical role in the actual consumption of healthy meals. In particular, family dynamics, such as competing preferences, food habits, or the influence of children and caregivers, can significantly affect meal preparation and consumption. This insight, along with the Journey and COM-B frameworks, highlights the importance of keeping human needs at the center of our work. By recognizing that behavior change isn't just about pushing individuals to act differently, but about understanding and addressing the underlying capabilities, motivation, and opportunities they face, we can create more effective, sustainable interventions. These frameworks also remind us that behavior occurs within a broader context, social, environmental, systemic, and that we must design interventions that resonate with real human experiences and challenges. Ultimately, our goal is to create solutions that don't just drive short-term behavior change, but foster long-lasting transformation by meeting individuals where they are, empowering them, and helping them navigate their journey in a way that feels relevant, achievable, and meaningful. Keep these insights in mind as you take time to complete your exercise worksheets. And thank you for joining us for today's session, Designing Targeted Interventions, Combining COM-B and Journey Mapping. We hope this session has helped you see how merging these two powerful frameworks, COM-B and Journey Mapping, can enable more nuanced, strategic, and human-centered approaches to behavior change within food is medicine research. By refining the food is medicine journey and anchoring it in critical behaviors, we can design interventions that are not only evidence-based, but also grounded in the real experiences of the individuals we serve. Whether you're designing studies, shaping interventions, or thinking systemically about implementation, this approach gives you a clear, practical structure to build from. In the next and final session, we will explore the human-centered design tool of personas, learning how to develop them, use them, and apply them within the COM-B and Journey Mapping frameworks we covered today. Thanks again for your time, energy, and engagement. We look forward to continuing with you in the next and final session.